Hello and welcome. My name is Joseph Ceramelli and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. And thank you for joining us for today's Grand Rounds presentation. For this academic year, our Grand Rounds series theme is called Next Steps in Care Include, which is a series of presentations on innovations and updates in clinical care. And there's a core group of us that work on Grand Rounds each week, including department staff member Semhar Abraha, who focuses on communication and coordination, and Michael Walker as the technology expert. The series is funded by the Ripley Fund and at times by institutes and centers in the department, such as the Garvey Institute for Brain Health Solutions. Note that today's presentation will be archived on the Grand Rounds webpage. And you can submit questions throughout the presentation using the Q&A or the comment area, and we'll reserve time at the end to go through those questions. I'll put the link for the Grand Rounds evaluation in the comment box during the presentation, and please complete the evaluation today after Grand Rounds concludes. Today's presentation title is called Partnering with Tribal Communities to Promote Well-Being and Decrease Opioid Overdose Deaths. And there are three presenters today. I'll say a brief introduction for each presenter, and then I'll turn it over to the first person who's speaking. First, Clinton Alexander is a public health professional with the White Earth Health and Behavioral Health Divisions, with over a decade of experience developing harm reduction programming that includes being a founding member of the White Earth Harm Reduction Coalition, and has also had an instrumental role in development of an innovative community-driven harm reduction program with peer-delivered syringe exchange and overdose prevention services. Dr. Brenna Greenfield is an assistant professor of family medicine and biobehavioral health at the University of Minnesota Medical School. And Dr. Greenfield uses strengths-based, community-grounded approaches to address substance-related health inequities and has partnered with tribal communities in the Southwest and Midwest for the past decade. And Heidi Goodwin, who will speak first, has more than 20 years of experience working in substance use disorder treatment settings and contributes to community well-being and recovery through advocacy and recovery groups, sobriety feasts, and community events.
Hi, everyone. My name is Brenna Greenfield. I am zooming in from Duluth, Minnesota, which is on Lake Superior. And Heidi and Clinton and I have both been working on Overdose Fatality review, which we're going to be talking about today and introducing you to. And we're really glad to be here and have this chance to speak with all of you today. And do you want to say hello, Clinton, before I jump into our slides?
Yep. Yes, thank you. Miigwech Heidi, Buju, Makwami Bisa Ndejanakas, Maingan Dodem, Gawa Babiganika Ganunjaba. As like Heidi said, my name is Clinton. I'm from the White Earth Reservation. I'm a enrolled member. I, like Heidi, come from the Wolf Clan. We have some roles in our clan systems, and there are a lot of implications of that meaning and our relationship to one another and what our roles are. And in a lot of way, our traditional role as Wolf Clan is to be helpers, and there's more to it. And I know Heidi could probably add to that piece, but this work is truly about survival of our relatives, supporting our families, and highlighting the innovative things that we do well and focusing on resiliency. So right now I work as the behavioral health director for White Earth Nation. And in my introduction, I talked about the role that I had with our harm reduction coalition, which was really a community-led, elder-driven an approach to keeping people alive. So I'm looking forward to sharing our information today. Miigwech.
Thank you, Clinton. And we'll be going back and forth between each other as we go through our presentation today. And we will save questions. Please feel free to enter questions as we're going through, and we'll take questions at the end. All right, our talk is called Partnering with Tribal Communities to Promote Well-Being and Decrease Opioid Overdose Deaths. And I'm gonna start by sharing the land acknowledgement from the University of Minnesota Duluth, which is where the medical school where I work is situated. We collectively acknowledge that the University of Minnesota Duluth is located on the traditional, ancestral, and contemporary lands of Indigenous people. The university resides on land that was cared for and called home by the Ojibwe people, before them the Dakota and Northern Cheyenne people, and other Native peoples from time immemorial. Ceded by the Ojibwe in an 1854 treaty, this land holds great historical, spiritual, and personal significance for its original stewards, the Native nations and peoples of this region. We recognize and continually support and advocate for the sovereignty of the Native nations in this territory and beyond. By offering this land acknowledgement, we affirm tribal sovereignty and will work to hold the University of Minnesota Duluth accountable to American Indian peoples and nations. And land acknowledgements have really started to surface all over in the last few years, and they're just really a first step in acknowledging tribal lands and the history of the United States. And especially for universities, they also need to be coupled with action in terms of decolonization and efforts to work with tribal communities and kind of restore some of the harms that have been done in the past. And at University of Minnesota, we just recently have our first senior advisor to the president for Native American Affairs, Karen Diver. So that's just an example of one thing that's happening here. And also recently, there was an announcement that all Native students who are tribally enrolled in Minnesota will have free tuition when they come to the University of Minnesota, which goes back to the land grant responsibilities of the University of Minnesota. A brief overview of today. So we're going to talk about the project background and goals. What is Overdose Fatality Review, which we'll abbreviate as OFR, the process we went through, findings from the meetings, and then we also did focus groups along with piloting Overdose Fatality Review and implications and next steps. So I recognize that this might be a bit out of what you normally discuss here in terms of psychiatry, but I hope that you'll be able to find something useful for your own clinical practice today. And I hope we have time at the end for questions as well. Maybe we can tailor some of this to challenges you're facing in your clinical practice. I want to acknowledge, first of all, individuals who've lost their lives to opioid overdose and people who care about them. Also, all of the Overdose Fatality Review team members, community focus group participants, and then there were many people who made this study possible. So this is a list of everyone that we partnered with. And our funding was provided by the National Drug Early Warning System, which is funded by the National Institute on Drug Abuse. Project background and goals. And this is where I turn it over to you, Clint.
All right. I know everybody knows how to read the bar graphs here and can interpret this. There's a piece of this from, I think, from the public health lens that I think is kind of very obvious, that the race rate disparity of overdose in our tribal communities amongst American Indians undoubtedly was a huge and continues to remain a huge issue. And I know, Brenna, when we talked about this, the policy side of this, there's this continued drive for us to, do this work to understand these relationships and these causal factors. There tends to be a continued burden on tribes to bring this need from the state, to allocate resources and funding. And that truly is a big part of what we did. And the other part of it really comes from the impact of this on our communities. When we talk about statistic, the ratio, we talk about death rates, there's a context of this that's always kind of left out and hard to articulate when we have 6,500 tribal members living on the reservation, 18,000 total enrolled members, nationwide, so to speak. Loss of one life in our communities has incredibly, long-lasting ripple effects. We also have this cultural context of understanding this loss that we see when you know, with Heidi is somebody who has you know, sort of a calling, so to speak, to help heal with our communities, and there are teachings and there are songs and there are practices that are passed on orally through family members, and these deaths sometimes include that, and that loss is permanent. So this really, I mean, there's a lot of levels, I think, that we could talk about this, and I think, you know, from the, you know, for psychiatry or for psychology and the mental well-being of our people, at the time that we really started doing some of this work around overdose prevention with our coalition, we were having 7 to 8 overdoses you know, in a week was normal. When we really began to move forward and we changed a lot of people's minds, we had 3 deaths within a 24-hour period on a reservation. This was back, it was Super Bowl Sunday, the same weekend that Philip Seymour Hoffman died of an overdose. And we were really beginning to dive in, and our elders really wanted us to take a look and say, what do we do to prevent this from taking more people from our community? A little bit longer than I wanted to kind of go with the slide, Brenna, but I think that additional context, I think, hopefully, you know, underscores that this is about equity and preventing preventable deaths.
Thank you, Clinton. Yeah. This next slide, I think you were going to start, and then I can add to.
Yeah, I mean, again, you see Minnesota, the rate of by race. Minnesota, I think in 2019 ranked 48 out of 50 for the overall impact of overdose deaths. But when you looked at American Indians, our rates of fatalities related to overdose were almost at the same level that we were seeing in West Virginia and some of the, you know, the communities that, when you look at the CDC infographics and things like that, you can see very clearly that our communities were impacted at the same way that communities in West Virginia and other areas that really started to become those hot spots.
Yeah. I think another piece too is that I just want to point out too that American Indian communities or populations in different states sometimes have lower rates than the overall rate, but that Minnesota and then actually Washington are the ones with the largest disparities. And so these data were what originally prompted people that we know at the National Institute on Drug Abuse to reach out and say, what do you think's happening in Minnesota? Is there something we could do about this? There's these national drug early warning system hotspot studies where we take some time and a little bit of money and look at an issue like this. And that was what gave birth to this hotspot collaboration and piloting overdose fatality review. And I hadn't worked with White Earth prior to this project, but White Earth had already been exploring doing overdose fatality review. So then that's when we came together to start trying this out. And where I work, I just want to mention, since you're also in a medical school, the University of Minnesota Medical School Duluth campus is one of the campus locations of the University of Minnesota. The other is in the Twin Cities, St. Paul, Minneapolis. And the mission of our campus, Duluth, is to be a leader in educating physicians dedicated to family medicine and serving the needs of rural Minnesota and Native American communities. And you can see here a picture from about a year ago with the medical students that have worked on teams with me right by Lake Superior. And our campus always has the most family medicine graduates, and then also the second most Native physicians that graduate every year, which is something that's been going on for many years and that we're very proud of.
This is a, I don't know, for the map, I know in the land acknowledgement, we talked about the 1855. There is.
That's mine, right? Yours might be different.
Say that again, sorry.
Oh, we might be in different treaty areas, right, Clinton?
Yeah, well, they're like, you can see the square on the image with the full state in the light green. That is the area that is the geographical boundaries of the White Earth band of Chippewa. Our White Earth reservation is contained within those, and when we think about policy, you know, you can see, I guess it's hard to see on this map, but I don't know, Brenna, if you have the mouse and you can point to like where Minneapolis would be, that large urban area. We have a large native population there as well. It was part of the relocation. There was housing that was set up there intentionally to pull people from the reservation into the urban areas. And then Duluth kitty corner on that side. And at one point, that the land that was part of our original treaty lands was including all of that essentially north of I-94. And today our land mass is defined by the 60 by 60 mile radius. And again, multi-jurisdictions, 3 counties overlapping. And there's a lot of, I don't know if we go deep into this part, but there's a lot of issues with jurisdiction that contribute to this as well. Go ahead. You know, early on with this project, we developed an overdose response committee, and as Brenna said, we were looking at fatality review when you know, our paths crossed. And I remember one of our first initial conversations, Brenna, about, you know, I can't remember specifically how you said it, but it was persistent that that we have an opportunity to get to what is the causal factors of it. You know, we were for the most part really in this very reactive piece, and so there's something serendipitous about this relationship and where we're at, and you know, then and where we're at today. You know, we talk about oral history, we talk about the history of this. Prior to 2018, 2017, what we were typically getting out of the media was these stereotypical type news reporting stories that oftentimes place the blame on the community, rarely acknowledged any type of resiliency or innovation of what we're doing, and we just collectively said we're going to change this narrative, and we worked very, very hard with with the counties that surround us, the law enforcement agencies, our tribal leadership, state leadership, and like partnerships with University of Minnesota Duluth is just another example of these types of headlines of the active efforts that we are taking in this and trying to keep that focus. When we think about the collective impact on our community's mental health and well-being, I mean, it still continues to be a challenge when we're surrounded by a lot of loss. And so a lot of our efforts really try to speak to that, or we try to really focus on making sure we address the collective impact on our communities. So these were two articles that we knew were very, really were accurate in reflecting our approach to this issue. And this is an amazing group of people. We early on, around the same time of beginning the Overdose Fatality Review, we talked about social connectedness, resiliency, and innovation. And for the last 3 years, or 2 years prior to COVID, this going out with law enforcement, going out with community members, communities of faith, all the social programs, and we went and had community gatherings throughout the summer, and it was just basically to tell people you're not in this alone. We're in this together, and there is help. There were no like educational presentations. It was really an opportunity to bring people together show support and really kind of strengthen that connectedness that we share as people, and even more so as Indigenous people. These pictures, I think about COVID and where we're at today, it blows my mind.
Yeah, thankfully the community picnic started happening again this summer, so that was really nice. So now I'm gonna walk through a bit what opioid overdose fatality review is. You may have heard about fatality review for other topics such as domestic violence or suicide, but overdose fatality review teams really originated from Maryland, where the state started piloting them to look at and review overdose deaths to try and understand what was driving them and how they could be addressed and reduced. And the goals of overdose fatality review, opioid overdose fatality review, are to identify what's contributing to overdose deaths, find ways to intervene and prevent future deaths, and bring together a multidisciplinary group to share knowledge. When we started doing our fatality reviews in Minnesota, I think they hadn't been done in Minnesota before. For overdose fatality review, Wisconsin had been doing some, Mallory O'Brien. And then at the same time, the Minnesota Department of Health was starting to pilot these in the city of Minneapolis. And now there's more of a focus throughout the state on having these teams meeting. And then for us, our overdose fatality review team was the first time that it had been done with a tribal nation. So that was part of the innovation that we were working on together. And to highlight again our partners without whom it wouldn't have been possible. The medical school where I work are funding from the National Institute on Drug Abuse and the National Drug Early Warning System, with whom we worked really closely. The Minnesota Department of Health provided information on death certificates so we could determine what cases to review. And then we have Gawa Babakanakug, White Earth Nation is our other partner. This makes up our team. And what we're sharing here today doesn't reflect the views of the National Institute on Drug Abuse. So the goals of our project, this hotspot study that we received funding for, were to identify factors that contribute to American Indian opioid overdose deaths, provide recommendations of ways to address these factors, and the ultimate goal being to reduce opioid overdose deaths and health inequities. So the process that we used was adapted from that article that I showed just a moment ago. And the representatives that we brought together came from tribal organizations like mental health, substance use, law enforcement, and ambulance services. And the data we reviewed included death certificates. We also looked up corrections records. And then each tribal organization representative that came to the meeting would look and see if they had any records on the individuals who had passed and then bring those to our meetings. And they would fill out a case report before each meeting about the information that they found. So this was new because people normally didn't have a chance to sit down together and carefully review what had happened with an individual who had passed from an opioid overdose death. And the number of participants we had at each meeting for overdose fatality review ranged from 8 to 14. Would you like to add anything else here, Clinton?
I know we dive into a little bit more. I think the process and the heaviness of how we address this to this day. I was going through some of this yesterday, and I remember one of the first rounds that we went through, and the needing to stop for people, the connectedness to one another, and that collective impact. I thought was going to probably maybe, I don't like to say scare some of our people away from wanting to do it. But I think what we found is that it really reinforced people's commitments to why we were doing what we were doing. Yeah.
That makes sense. So some of the innovations that we brought to this, we obtained a tribal resolution to support data sharing. So tribes are sovereign nations and can issue tribal resolutions, which reflect laws and things that need to be followed. So this tribal resolution, we didn't have access to autopsy data for the 3 meetings that we held of overdose fatality review. But if we were to have continued it, we might have used the tribal resolution to obtain autopsy data or data from local hospitals, things like that. We also added a social media review. So a lot of people were active on Facebook, and what we did is looked to see from their posts, the people who had passed, what was going on in their lives, and also to bring in the strengths of each individual. And that was something that everyone in our group really wanted to focus on, because in such a small community, many of the people participating in the overdose fatality review meetings, even though they hold positions like the medical director or things like that, also know the individuals who have passed. And that, I think, was quite different from, say, a review that happened in a large county in Maryland, where the people who are at the table doing the review don't know the individuals who have passed. So that necessitated us reviewing fewer cases at each meeting and slowing down and starting each meeting with traditional cultural practices, so that we were also taking care of the participants of OFR while we were reviewing the cases. And we had a cultural coordinator join each meeting and just make sure that we were holding the meetings in a good way and gave us feedback on how they were going. Now we want to share with you the findings from the meetings that we held. And we reviewed 5 cases total. The individuals had died between 2015 and 2017. They all lived on the reservation and were American Indian. And on their death certificates, it listed opioid or drug overdose as the underlying cause of death. And the meetings that we held were in between March and May of 2019. We released the hotspot report. I'll give you the link to that at the end. That summarizes everything that we did in December of 2019. And it happened to be the day that Donald Trump was also like getting impeached. So I think it got lost a little bit. And then we've had the pandemic. So we'd encourage you to take a look at that now. It's still relevant, we think. And we identified these 5 themes as contributing factors to the opioid overdose deaths of the individuals whose files we reviewed. Would you like to talk about this, Clinton, or should I?
You can. I would just, you know, really the hesitation and refusal to call for assistance, I think really speaks about policy. And if we think about where we're at today, you know, Heidi, I know, has been involved with some of the community rapid response with our public safety department. You know, our spike alerts or any kind of public health notifications that go out really speak to one of this one here, you know, that help is available. And so the, you know, contributing factors and the impact of what we learned and what we've been able to keep focusing on has been huge. But I'll let you.
Okay, yeah, I'll go through these. And then maybe if Heidi wants to chime in too. So from the 5 cases that we reviewed in doing this multidisciplinary review, the first one that Clinton mentioned is that people felt uncomfortable or nervous to call if there was an opioid overdose. A second one was that there needed to be more coordination with substance use disorder treatment services. So particularly if people were going off reservation for residential treatment or outpatient treatment, then there were gaps in care, and those gaps in care would contribute to overdose deaths. Also addressing medical and mental health needs. A fourth one, we had looked at that map earlier. So the urban area, particularly we're referring to as Minneapolis, St. Paul, which is about 4 hours from White Earth. And there's a lot of movement between the reservation and urban areas, which is driven by US relocation policies, but that also can make it difficult for people to have continuity of care. Finally, the last one was data accuracy and availability. So we found at our meetings that we wanted more data on what had happened to individuals, how they were doing. We didn't have all of their treatment records. And this is a problem in many healthcare systems and organizations that are trying to work together. But I think particularly in tribal communities, there's also an issue where sometimes there's a lot of data being collected on tribal communities by state or the federal grants, things like that. But then that data isn't always shared back or easily available for tribal communities in a way that would be useful for them. I think I'll keep going to the findings from our focus groups. So in addition to holding these 3 fatality review team meetings and piloting this process, we also did focus groups before and after those meetings to understand what the overdose fatality review team members thought about doing OFR. And we also had community focus groups before and after. And here I just summarized who participated in those focus groups. So the OFR team, those were people who were participating in the OFR meetings. And then the community focus groups were people in community leadership positions or who were active in addressing the opioid crisis. And we had about like 4 to 8 people at each focus group. And you can see here the topics were the same. What do they think about fatality review? How well does this fit culturally? And then this last one, what they saw as protective and risk factors for opioid overdose in their community. That's what we're going to be sharing those results with you right now. So from the focus groups, these were the main findings for protective factors and risk factors for opioid overdose deaths in the community. Would you like to talk about this, Clinton, or shall I?
You can.
Okay, sounds good.
Please.
Or Heidi, do you want to jump in or should I keep going?
You could keep going a little while there. You're doing good.
Okay, I think you two will take it away at the end also. All right, so protective factors. Well, I'll start with the risk factors and then we'll end with protective factors. So the risk factors, big one, implication of historical loss, which included things such as loss of land, loss of language, suppression of language and religion from US policies, and boarding schools as well, which is something that's really been in the news a lot more recently. Historical and contemporary trauma, shame and stigma. So that was in relation to drug use, that people might be embarrassed to tell people that they're using, things like that. Another risk factor was the intergenerational effects on children when family members are using or when people in the community are lost. And finally, jurisdictional issues and rurality. So White Earth Nation covers a lot of land and it can be a long ways to get to the hospital, or it can take a while for an ambulance to come, especially we get a lot of snow in Minnesota. If you've ever seen Fargo, we get more than Washington State. I'm not gonna, don't hold me to that, but these are things that make it harder if you're trying to help someone who's having an opioid overdose to get to them. In terms of protective factors, there were a number that came up again and again in the focus groups. One was cultural traditions and strength, the resiliency of Anishinaabe people. Also naloxone availability. I know across the country at this time, there was really variability in how easy it was to get naloxone. And White Earth has been pursuing innovative solutions and making sure naloxone is very available for a long time. Finally, social connectedness, that people really care about each other and are willing to help each other as much as they can within the community. So I'm going to read 4 quotes now from the focus groups to highlight some of these themes related to risk and protective factors. The first one is about historical and current trauma. This is from a community focus group participant, and they said, the death certificate saying that these people died of overdoses, but it's not most of them. I'd say 90% died of broken hearts. It's the trauma that our people go through. It's all the deaths, the losses that our people face. And this is working on the front line, seeing this stuff firsthand. And I'm trying and doing my best part, what I can do for my people that I work with, and trying to get to the bottom of their addiction that became something that became an addiction. Because that first initial hit of that drug, it numbed that pain that they felt. The next quote is about culture as a protective factor. We have our culture, we have our revitalization and restoration of our language, our ceremonial practices, and the other part is our humor. It's the cornerstone of healing. We can laugh at some of the most atrocious things and people may think we're insane, but we have an incredible sense of humor. Innovative solutions and resilience. There's a lot of community strengths, and the fact that we're actually still here, we survived genocide. We're very much a resilient people. We're intelligent, we're caring, and we're loving. We're always coming up with solutions to find what's going on and try to respond to what's happening within our communities. We know what our problems are, and we as community members know what those solutions are. All too often, we have too many Western programs trying to come in that don't fit. They don't fit standard rest of the United States. Why would it fit here? Tribal communities, which are very distinct and different. And finally, a quote about naloxone availability. When ODs are happening, there's notices on Facebook from the tribe saying they're here, we're handing out Narcan, all of these different things. They're available for coming into communities and into programs wherever to provide Narcan trainings and to distribute Narcan. Lots of awareness, lots of education. So we're moving into the last bit now about implications of this work and what's been happening since. And just to summarize about opioid overdose fatality review, it's really a way to take a novel look across different systems to find ways to improve them to prevent future overdose deaths. And what we found that was really neat at the meetings of the different representatives from organizations is that as they learned about things that could have contributed to overdose deaths, then they were very eager and ready to address those things in their systems and made changes. And this may be a useful strategy to implement within other tribal communities and settings, and it can align with Indigenous cultural beliefs about death. Future research should also look at OFR's potential to contribute to community healing and inform community interventions that address the cycles of trauma. So implications of our work is you, Clinton.
Yep. This is where I think, you know, we continue to try to look at the barriers and facilitators of you know, the access in this evidence-based treatment. How do we continue to develop? How are, you know, these pathways, when we think about the, you know, most treatment facility beds are available in urban areas. You know, I know nationally there's data that shows that disproportionate number of beds are available there. The rural isolation stigma, that while it has that, it can be a protective factor, it also can be one of those barriers in terms of confidentiality and where you share looking for help. So that stigma, so it's kind of a double-edged sword in some ways for us, and then the limited number of providers. Like Brenna said, as we were going through this, the sense of let's act on this, and we've got to take action, and we've got to address these things. You know, the people that were part of this, as well as those that work with our coalition and have been part of this, have continued to look at these, you know, for practical strategies, things that we can do. You know, when we look at research, we continue to ask that question of what's the immediate benefit to our people. Tribal communities have been researched in very exploitive ways historically, and you know, there's some of that hesitation in this, but what we're seeing is in our community, as they've seen the value of what we've done with research and being active partners, really help us understand what are some practical strategies. So improving access to evidence-based medications, MOUD, the naloxone Narcan access, and then the psychosocial services, understanding that holistic need continues to be one of the big implications that we look at now, and how we're providing services, and even taking a look at realigning our treatment standards within our programs and making sure that this is very comprehensive. And I know we talk about it a lot of times, that we have a holistic approach, but I think when we continue to take this critical examination the way we have, it shows that we still have opportunity. A piece for me that really I'm glad became one of the big implications is this building trusting relationships, compassionate care, and embracing non-coercive and meeting people where they're at. Really the harm reduction philosophy, which in our traditional way, we say is a traditional value, because our people are not disposable. They're our relatives, we care for people, and we need to treat and meet them where they're at. I think the partnerships with local harm reduction syringe exchanges continue to this day to be a lot of interest. We work collaboratively. When you look at that map with public safety, human service programs, to the east of us and over to the west of us, communities want to be part of the work that we do. And at the end of the day, one of the things that just really becomes a simple reminder for us is that there are many meaningful ways and pathways to what recovery can be for somebody. And I think some people may recognize the name of Dan Bigg. Chicago Recovery Alliance is famously known for that. Any positive change is essentially what recovery is about. And so I think the implications of what we're learning from this and the continued way that we are addressing the issues reflect these implications. Since completing OFR, like these things just never stopped. We just kept moving. I've already talked about the hesitation, fear of calling 911. Our public safety director, we've had meetings with, public safety, the sheriff's departments from other parts of the state. And when they come into our circle and these conversations, one of the things that always I kind of chuckle is because our public safety director does not stick to the script of what typically you would hear from public safety. When our public safety police chief, when we have an overdose, the first words out of his mouth are, "Come on, people, don't use alone. Call. We will get you help. We're not wanting to take an arrest." His commitment. He stands by it. He's conflicted, as many of our public safety people are, because of the emotional pleading that they get from family members. Lock my kid up. So our public safety director, our public safety team have been invaluable. And I don't know, Heidi, I saw you shaking your head. I don't know if you want to jump in and add anything, because I know you've got to work with our CSOs, and I think that's a huge piece of this.
Yeah, just want to add like a lot of the things working on the front line, what it really has become since all of the I seen this group come into life, all of the things that have been changed, all of the things that have come to life as being a part of the CAB, being a part of our community, being a part working in this field, working on the front line, and to be a part of this is and seeing all the changes that are being made is amazing. And I'll add more, because I know there's going to be more to talk about on what are some of the things that we are doing here in White Earth. So I just want to I'll end there and have Clinton take a little bit more, but I will have a lot more to say. But all the good things that are going on here in White Earth.
Yeah. I think, Heidi, the coordination, we said that one of the second contributing factors is coordination of SUD services. And, so we continue to look at You know, we were scheduling assessments. You know, in Minnesota, there's the Rule 25 assessment, chemical health assessment, and then the comprehensive assessment, which is part of reform. And White Earth is part of that early rollout of the comprehensive assessments. And in the way that we were treating and the way that we were looking at this, the point people were being scheduled out. And so one of the things that really stood out, you know, 2 years ago, we had 50 some people that attempted to get an assessment in 1 month that were unable to get it. By changing our focus and taking what we learned from OFR, we, within a 60-day period, in 2021, from January and February, by moving to a model of walk-ins, extended hours, I believe the number was close to 100 individuals that received on the spot, you know, on-demand chemical health assessments. Because once, I mean, I know this group probably knows this as well, very well, but without that diagnosis, without that assessment, billable services, you know, don't begin for the most part. So we put a lot of focus on that. We're really looking at medications first, giving people a little bit more lead time on induction into our MAT programs. Partially because of COVID, but also because we know that it's needed. People need that time to stabilize, to get, you know, essentially to stabilize the chemical balance and help make better decisions. And then medical mental health coordination. We continue to meet every 2 weeks collectively with our kind of the first responder crew to just brainstorm what's working, what's not, so that we don't, we can't go backwards. And then ultimately, and this is probably where Heidi, I'll end with this and let you finish, but the connection to our spiritual and traditional practices, that the cultural resiliency that we talked about, really goes back to this prevention idea of strengthening a cultural identity. Our approaches are, you know, with the community service officer wellness navigator, a big part of that is building in our traditional practices into how we respond to loss of life or an overdose. And I don't know, Heidi, if that's where you want to jump in. And
sure. So there's protocol to all the things that happen with death, with life even, you know, there's a lot of protocol that we have to take culturally, traditionally. And you know, when these things happen, we lose a loved one in our village. You know, there's protocol that has to happen. The fire has to be started, and there's protocol to that fire being started, and the teachings that come with the fire, why we light that fire. You know, there's tobacco teachings, why we put that tobacco in that fire. There's why we put food in that fire. There's all these different things, and then getting the body ready, prepared for its journey to everlasting life. You know, and so there's a lot of teachings that we shared that we couldn't share before, but now that we're able to talk about these things and to share these things, so now that it's more readily available for our people, that we do share these things with them and why we do these things. And so and in the cultural part of our healing, and how do we heal, you know, with our traditional way of life, our medicines that we use, our ceremonies that we hold. You know, we talk about our cedar ceremonies being that that's like wiping. We also use that as wiping of the tears of losing a loved one, we have a ceremony that's called Wiping of the Tears, and also another cedar ceremony that's wiping away all the stuff that we've endured throughout our youth, throughout our life, wiping that stuff off to give us permission to start to live again, to wash all them things that we've endured, them bad things, them teachings that we had to learn in a real hard way. So there's all the things that we've been doing, and it's amazing to be a part of this, because it's just to see it's almost like watching a cocoon, and watching that person peel out that cocoon to a beautiful butterfly, and to be a part of their journey, just to be a little part of their journey, to give them direction in a good way, with using our cultural, with using our healing, or with using our traditions, is a really, really awesome and amazing journey that I've been on, to be a part of this, and thanking Clinton and Brenna for allowing me to be a part of the CAB, to be a part of this summit, of this meeting today. And I just want to end with saying miigwech to everybody for allowing us to this time. Gigawabaman, we will see you. Hopefully we will see you sometime soon. There's no goodbyes in our language. It's Gigawabaman, Minowa, see you later, see you soon, see you sometime down the road. So with that, I just want to say you. That's all I have to say, miigwech.
Good, Heidi.
How? Oh!
Okay, thank you, everyone. We have just a couple of minutes, and one or two comments and questions came in. I'd like to encourage participants, if you have a question, we'll try to address it in the few minutes we have remaining. And this point, a question came in. I believe you've covered this and addressed this extensively, but perhaps you'd like to comment to a question that came in about Indigenous peoples more likely to die from overdose due to biological predisposition, or due to disparities in healthcare or other services, discrimination, other factors. Again, I believe you've covered this. Perhaps you want to say more.
Yeah, I think there isn't a biological predisposition. The same goes for alcohol. There isn't a biological predisposition to alcohol dependence or use disorder. So yeah, I think we did cover the other factors, hopefully, in our presentation.
Yes.
Brenna, I was going to just add this layer of, when you think of structural racism, I guess being born American Indian is a biological factor. And when we face a very fragmented, underfunded healthcare system, despite a treaty responsibility, things like that. I mean, it's kind of a tongue-in-cheek kind of take on the biological side of that, but yeah, it's a huge issue.
One question came in about privacy rules, about maybe as a barrier or obstacle to identifying coordination of care for substance use disorders across law enforcement, emergency department, treatment programs. Is that an issue that comes up? Do you encounter that? You've mentioned crossing multiple jurisdictions. Is communication hampered at times by these privacy rules?
The thing that in general, there has been. The way that we collectively work these days, and where we have behavioral health people implemented within the police department, they do dance they walk along a pretty fine line at times about what they can and can't do. There are areas of what can be shared, what can't be shared. In emergency situation, even within some of the CFR language about, you know, what type of information can be released. You know, that is why we meet frequently, for two reasons. One is to address that, but these bi-weekly meetings, we really try to bring, I guess one of the initial meetings that we had after people started coming back into the offices was this acknowledgement that the 6 people that were in that room that day represented the crisis team, mental health, public safety, our public health, behavioral health, like mental health. And we figured that if these 6 people didn't know who each other were, didn't know how to access services, how do we expect community members to do it when we can't articulate that and we can't figure that out? So we do spend a lot of time figuring out protocol and how we do that. A month, maybe, how our sense of timing has gotten. I think 2 months ago, one of those scenarios played out with, we had experienced the loss of life of several young people in an automobile accident in the middle of a community healing ceremony. We got a call of an overdose in that little community of 400 people. And the overdose officer, where I'm going with this is that this coordination and the way that we talk about these services of one of our community members went from overdose unresponsive to our MAT program, in the intake completed, dosed, and into a treatment bed within just a couple hours. And so this communication and things like that, and these barriers with CFR, we continue to actively try to solve it. You know what I mean? Like we've got to figure this out, because if we can do that in that situation once, we should be able to do that anytime.
Well, Clinton, I think. I'm sorry. You commented about there being maybe initially a lack of reporting on innovation, but here's an innovative way of getting people to communicate with each other that has solved and addressed a clear barrier. It's interesting. Yeah. Well, Brenna, Clinton, Heidi, thank you for presenting today and for having 3 people describe these projects, findings, and the work you've been doing. We're at the end of the Grand Rounds presentation today, and thank you again. And we'll leave it at that and end our Grand Rounds presentation.
Thank you. Take care, everyone.
You guys.